everyone, this is Dr. Patel with Gaya Wellness, and I am doing my Facebook Live today on the topic of bleeding after menopause. And that's a very important topic, mainly because a lot of women will experience this without really bringing it to the attention of their healthcare provider, thinking it's probably nothing. And likelihood is that it is probably nothing, but in the small chance that it is, it could be something really important. And so I definitely encourage any woman who has at least had a year since her last period and is now meeting the criteria of being in menopause once she is in her early to mid 50s, which is national average age range, that if you have not had a period for over a year and meet the definition of being in menopause and then you start having bleeding, even if it's a little bit, it needs to be evaluated. The primary concern we have when this happens is the possibility of it being a cancerous process. And that's what we typically want to evaluate first and foremost. So the best thing to do is bring it up to your doctor, and that way we can do a very easy and quick evaluation, usually involving an ultrasound and seeing if there's anything inside your uterus that's actually precipitating the bleeding. How much bleeding you're having also kind of indicates what it might be from. And I actually, not to get a little weird or maybe a little too graphic, but the color of your bleeding. Bright red bleeding usually might be something related to the vagina having small tears or scratches from the fact that there's not as much estrogen and things are more delicate and fragile. And sometimes even by wiping or scratching, you can actually create small cuts which lead to bleeding. And that'll still present to a woman on her underwear or on her panty liner, and it'll be bleeding after menopause. The typical, appearance of that kind of bleeding is where it's bright red, it's very little, and it's not persisting. However, if you start to have bleeding like you are starting your period all over again, or it happens and then it stops, doesn't happen again, and a few months go by and it happens again, anything really beyond that little bit of pinkish discharge that I kind of described that could be attributable to vaginal atrophy needs to be evaluated. And the potential causes for that could be that you're having bleeding through your cervix. The causes for that could be if you have an infection or irritation in the cervix that's causing bleeding. If you have a polyp that's in your cervix, cervixes or cervices can also have polyps, and it working our way up into the uterus. If you have a polyp in your uterus or a fibroid in your uterus, even though most women, once they're in menopause, should not have any bleeding from polyps or fibroids, they can still have their own, drumbeat, and sometimes have a little bit of bleeding or breakthrough bleeding with trauma or sex, exercise, etc. And so if that's the case, again, we can probably detect that on ultrasound and a pelvic exam. And the other thing, or more like the primary thing I would be looking for on an ultrasound, is how thick your lining is. The lining is what we build up every month as we're getting ready to have a period, and then what we shed when we see our menstrual flow coming out. So that lining, I usually make the comparison of it being like the lawn. And every month when the lawn is mowed, you have your period. When you are in menopause, it should be like a putting green in there at all times. And if you are having tall grass when you're in menopause, something's up and we need to evaluate it. So how do we typically do that? It's called an endometrial biopsy, and that is basically where we take a small sampling of the lining of your uterus. How we do that is usually in the office setting, and there is a small device that's comparable to the diameter of a pen ink cartridge. It's a straw, and we insert it through your cervix. It can be a little uncomfortable. I would definitely take some ibuprofen or Tylenol beforehand so that you are not feeling cramps or it's a little bit more comfortable for you. You can also talk to your doctor about having medication to prep your cervix the night before so that it's easier for it to go, this pipelle to go in. You can also talk to your doctor about getting something for anxiety and or pain beforehand if you particularly do not tolerate exams well. And by the way, that you can do that with any pelvic exam. I don't think women know that they have that right, and or that they can kind of raise that concern about feeling discomfort during a pelvic exam, be it for a pap smear or for anything else. You can always ask your doctor if they can do something that can allow for you to be more comfortable in the form of pain control. Okay, so with that being said, the straw is passed through your cervix, and kind of like the old school Tropicana commercials where you had the straw and you poke it into the orange, it's the same logic where we are poking small jabs at the lining of the uterus. And I hate to use the word jab but it is kind of what we're doing. And we're suctioning up a small piece of tissue with each poke using the straw as a vacuum suction. It is all done manually. It's not a very technical procedure, but the sheer act of something going through your cervix and something being poked inside the lining can cause some significant cramping that could be avoided with, like I said, something beforehand. That tissue sample is then sent off, and we have the pathologist review it to see if there's any concern for abnormal cells that would indicate precursors of cancer or cancer itself. It is possible with the endometrial biopsy that it could miss abnormal cells. We are doing it blindly, and what that means is not like I close my eyes and do it, but I am passing the straw through a cervix into the uterus, but I actually can't see inside the uterus. I am poking at it, kind of like when you are looking through your purse with your hand and you're just kind of looking around, feeling for something in your purse. You are blindly looking for something in your purse. Same thing when I'm not actually looking inside the uterus, but I'm passing an instrument through trying to take samples. I'm blindly taking samples, hoping that I'm getting a uniform sample size that will allow for a negative test result to be reassuring that I am actually ruling out the possibility of cancer in the entire uterus. Now, the only concern with that is, even though it's a very accurate test, in that the likelihood of having a false negative result with an endometrial biopsy is very low, meaning if you have a negative test result, it's usually accurate. But nevertheless, there is one more test that you can do. It's an actual procedure, and that procedure, in my opinion, is theoretically more accurate because the procedure is where we insert a camera inside the cervix and into the uterus and then take a sample, allowing for me to actually see the lining of the uterus and see if there's anything physically abnormal looking, and then sampling that, making sure I get a sample of that, in addition to making sure I get samples all around. These kinds of procedures can also be done in the setting of the office. We have some high-end technology nowadays, so we have what we call a hysteroscope, or a camera that goes inside the uterus that is very comfortable, very small, and can be done with the same level of medication as if we had done the endometrial biopsy manually. So you can talk to your doctor about using that option. I feel like my patients, when they have a negative test result with a hysteroscopic biopsy, I sleep a little better knowing that it wasn't because maybe I skipped the small lesion that was there because I was biopsying everything around it because I could not see it. Now, once that's back, then we can focus on whether this is a persistent issue and what we can do to fix it. If you are negative with your biopsy results, then some of the ways we can alleviate bleeding is using a DNC, or where we scrape everything out from the uterus so that any extra buildup of tissue that may still have been there even after menopause can sort of be taken out. So basically mowing a lawn one more time. There are medications that could be given to you if it's a matter of the lining having built up and you're in menopause, such as progesterone medications. An IUD can be considered, but usually postmenopausal bleeding isn't something that is perpetually going on. So it's more of a process of just ruling out that it's not cancer. And then if it's still an issue, we deal address the actual issue. Other potential causes, like I mentioned, could be that if you are on a medication like a blood thinner, if that was something that you recently started and you were not having any bleeding before, but now suddenly you are, even in menopause. And that could be because the blood thinner medication is making things that would otherwise have not bled easily start to bleed a little. And so something to kind of keep track of. All right, so to recap, bleeding after menopause, no bueno. Simple and easy to evaluate that and to potentially fix it. The biggest concern being that we want to make sure it's not uterine cancer. Uterine cancer, if detected on a biopsy, would be something we would refer you to a gynecology oncologist to be further evaluated and or have your options for surgery, etc. discussed. If it is not abnormal cells on the biopsy, then we can watch it and or follow it by doing another ultrasound in a couple of months and or making sure it doesn't persist. Ways we can do a biopsy would be in the office setting using just the endometrial pipelle, which is like a manual blind biopsy, or we can do a office hysteroscope, which would be where we would insert an actual camera into the uterus and do a more targeted biopsy. And you always have the option of talking to your doctor about having a more comfortable pelvic exam by discussing what pain options you have. All right, guys, thanks so much. Happy Cinco de Mayo. And I know some of you have been asking when you can start making appointments. We're still on track to do a soft launch for my telehealth on May 15th. I realize that's a Sunday, so we're going to actually officially take appointments starting Monday. And with that being said, the first 2 weeks of telehealth will be free when I start. So I say that just in case we get delayed because of the technicalities of everything. But once we do take off, hopefully I'll be able to gauge how helpful this service is for all my patients and kind of go from there. Have a wonderful day. Have some tacos, have some margaritas, enjoy the day, and I will talk to you next time.